my second talk is on the fibrotic lung diseases. We had a nice example with the case presentation of PPFE, Pleuroparenchymal fibroelastosis, and we are going to see the other fibrotic lung diseases. So this is the outline of my talk. So I'm going to start with the two principal fibrotic lung diseases. Then we will see in general which are the CT features in pulmonary fibrosis, what is the approach to diagnosis. Then I will talk about the recent diagnostic criteria for UIP, which have been published in a white paper from the Fleschner Society in November 2017, so very recently. And briefly I will mention PPFE. So the two main fibrotic infiltrative lung diseases are UIP, usual interstitial pneumonia, and non-specific interstitial pneumonia. It's very important to make the difference between these two entities, and I will start with UIP. Most UIPs are idiopathic, and so it's nearly a synonym for IPF, which is idiopathic pulmonary fibrosis. It is the most frequent among idiopathic ILDs, and the patient's characteristics are the following: mean age of 65 years, and the prevalence is higher with growing age, and there is a slight male predominance. There are some risk factors like environmental or professional exposure, smoking history, esophageal reflux, and some genetic predisposition as well. There are familial cases involving a deficit in the telomere function. The prognosis is poor with a median survival of less than 5 years. By contrast, most of NSIPs are secondary. They may be due to connective tissue diseases, especially systemic sclerosis, or they can be drug-induced. The patient characteristics are different from those of UIP. Younger patients and women are more frequently affected. The prognosis is better than for UIP. We can have a spontaneous improvement, stability under treatment, but also in some cases advanced fibrosis and death. So just to summarize, UIP is most frequently idiopathic. The idiopathic form of UIP is called IPF, idiopathic pulmonary fibrosis. When it is secondary, it can be secondary to some connective tissue disorders, especially rheumatoid arthritis. It can be due to asbestos exposure. It is the form of fibrosis which complicates hypersensitivity pneumonitis. At the chronic stage, a fibrosis develops and it takes the form of UIP, and it can be also drug-induced, especially with amiodarone treatment. NSIP is very frequently secondary to different connective tissue disorders, especially scleroderma and also myositis. It can be drug-induced with different treatment, and it can be seen after a severe infection with alveolar damage. As you can see, the prognosis of these two fibrotic diseases is very different, with a much better prognosis for NSIP. Regarding the treatment of these two fibrosis diseases is different. For idiopathic NSIP, it improves on steroid therapy, whereas for UIP, we know that steroids have a deleterious effect. But there are newly released antifibrotic therapies, such as nintedanib or pirfenidone, which allows having a slowdown of functional decline, even though there is no significant reduction of death and exacerbation. So you can see it's very important because of the difference in prognosis and because in the difference of treatment to make a clear distinction between these two fibrotic diseases, fibrotic entities. Now, what are the city features which can be seen in a pulmonary fibrosis? First is ground glass. You all know the definition of ground glass. It's an increased attenuation, not obscuring the underlying pulmonary vessels. So it can be due to filling of the alveolar spaces, but it's not the case in fibrosis. In fibrosis, it is due to a thickening of the alveolar walls, and this thickening is due to development of fibrosis, here in orange, or to the presence of inflammatory cells, and there is no obliteration of the alveolar lumen. Second common city feature in pulmonary fibrosis is reticulations, also called intralobular lines. They are due to a thickening of the intralobular septa, and you need to know that at the early stages it can have a nodular appearance. Third feature, traction bronchiectasis or traction broncholectasis. It's a passive, tortuous bronchial dilatation, you know, with very here irregular shape of the bronchial lumen inside fibrotic areas. You have other examples here. Fourth city feature is honeycombing. Honeycombing is characterized by clustered cystic air spaces, usually between 3 and 10 millimeters in diameter, but sometimes larger. They are predominantly subpleural with well-defined walls. It's the distinction with centrilobular emphysema, which has no defined walls. And there is a lack of normal lung between the cysts, and it's this characteristic which is very different in cystic lung diseases. You have some normal lung between the cysts. Honeycombing and traction bronchiectasis are sometimes difficult to distinguish. They can be present in the same territory, and it's difficult to make the difference if we only look at standard images. But if you use minimum intensity reformation with a slight thickness of 5 millimeters, it helps the distinction. Here it's very difficult to see that this airway lesion is a dilated bronchus, but with the minimum intensity projection you can see that it's in fact part of the bronchial lumen, which looks like a cyst but which is not a cyst. So use minimum intensity reformation based on the standard reconstruction algorithm, and it will help you making the difference between honeycombing and traction bronchiectasis. Fortunately, and I will talk about that in a few minutes, making this distinction is not as important as previously with the new Flashner criteria. Just to be relaxed, you need to know that the inter-reader agreement, even among chest radiologists, is not that good, so it's not so problematic to make the distinction. There are some differentials for honeycombing in smokers. Paraseptal emphysema, there's a single layer of cyst, and also an entity called airway enlargement with fibrosis, which I think is relatively mysterious, but it's characterized by a middle area predominance, and there is no functional impairment. If we compare CT of the same patient from years to years, we will see that ground glass may transform into reticulations, and we will see that reticulations may transform into honeycombing. So these different CT features are relatively correspond to different stages of a fibrotic process evolution. There are other signs of pulmonary fibrosis: architectural distortion, the deformation of the fissures, or volume loss, but these are not specific. It's some changes that you can see after, for instance, a pleuritis as a sequela of pleuritis. It's not specific for pulmonary fibrosis. It's interesting to look for additional features, especially presence of hiatal hernia. We know that reflux is a risk factor for IPF, or idiopathic pulmonary fibrosis, and hiatal hernia is seen in approximately 40% of patients with IPF. It's important to look for esophageal dilatation, because in the patients with fibrosis, this will strongly suggest systemic sclerosis, especially if there is alimentary stasis inside the dilated esophagus. You need to systematically check the pulmonary artery diameter and compare the ratio of the pulmonary artery and that of the ascending aorta. A ratio above 0.9 has 83% specificity for pulmonary hypertension. Additional features such as pleural plaques. It's in pleural plaques, important to suggest diagnosis of asbestosis, and we need to check for the presence of pulmonary nodules in every patient with pulmonary fibrosis, because pulmonary fibrosis is a risk factor for lung cancer, not only in patients with scleroderma, but in patients with pulmonary fibrosis in general. So here is an example of a lung cancer in a patient with pulmonary fibrosis. It's very important to review all images using minimum intensity projection and check for the presence of nodules. What is the approach to diagnosis? First, you have to answer that question. Is this infiltrative lung disease a pulmonary fibrosis, yes or not? And for this, you have two very reliable signs. If you see either traction bronchiectasis or unecumbing, you can be very sure that the patient has pulmonary fibrosis. Other signs, such as volume loss or architectural distortion, are less reliable. They can be due to former pleural infection. And the other signs, such as ground glass and reticulations, they are not specific for fibrosis. Two examples here. This is a patient with pulmonary edema, ground glass, not due to pulmonary fibrosis. And here, intralobular reticulation, causing what is called crazy paving in a patient with alveolar proteinosis, no fibrosis. So the only two signs, very reliable, are unecumbing and traction bronchiectasis. Then you have to answer the next question: what is the predominant feature? Is it ground glass? Is it reticulation? Or is it unecumbing? Here it's ground glass. Here it's unecumbing. Here it's reticulations. Then you have to analyze the distribution in the axial plane. Is it a subpleural predominant disease? Is it a peribronchovascular predominant disease? Or is it a diffuse disease? And then you have to analyze the predominance in the vertical plane. Is it basal predominance, mid-lung predominance, or upper lobe predominance? And when you have all these informations, you can decide if the patient has UIP pattern or NSIP pattern. For UIP pattern, the predominant CT features are reticulations and honeycombing. If honeycombing is not present, this does not exclude UIP, but if you have honeycombing, you can be pretty sure the patient has a UIP pattern. And for a UIP pattern, you need to be sure that the ground glass extension is less important than the reticulations. Regarding the distribution, there is a basal predominance for UIP, a subpleural distribution, and the distribution is very frequently heterogeneous and asymmetric. Another very interesting sign is what is called pulmonary ossifications, very small calcifications within reticulations. If you have at least 10 calcifications with a bilateral distribution in a patient older than 65 years, the positive predictive value for IPF, for idiopathic pulmonary fibrosis, is very, very high. And it is not a sign, pulmonary ossification, that you will see in an NSIP. So to summarize, you need to have reticulation or an accompanying in a basal subpleural predominance with a limited extension of ground glass. And if it is seen in an old patient, older than 65 years, and if you have pulmonary ossification, it's very, very suggestive of UIP. And if you have excluded some etiologies, it will be idiopathic pulmonary fibrosis, IPF. These are two examples. In these patients, you have onecambing. You have that basal and subpleural predominance. You have very few ground glass. And in this patient, you don't have clearly onecambing, but it's not the reason why you should exclude UIP. Onecambing is not mandatory for UIP. Reticulation alone are sufficient. Now, what are the features for NSIP? NSIP is non-specific interstitial pneumonia. It's the contrary to UIP. Ground glass will be predominant over reticulations, as you can see here. We will have some traction bronchiectasis, and onecambing is very infrequent. Similarly to UIP, there is a basal predominance, but the distribution in the axial plane is different. It can be peribronchovascular or diffuse. And this is not the case for UIP. A peribronchovascular distribution excludes the diagnostic of UIP. There's another CT feature which is very suggestive for NSIP. It is subpleural sparing. It's seen in approximately 1/3 of cases in NSIP, and it's very infrequent in UIP. So what is subpleural sparing? It's the fact that there's a subpleural sparing, so no abnormalities close to the pleura as seen here. There are different stages of NSIP. An advanced stage where you will have a lot of traction bronchiectasis, but there are also early stages in which you will only have ground glass without traction bronchiectasis, and in that case we talk about cellular NSIP. So to summarize the differences between UIP and NSIP, in UIP you have onecambing, more reticulation than GGO, a peripheral predominance, and you might have small calcifications, small pulmonary ossifications within the reticulations. In NSIP, ground glass is predominant over reticulations. You might have subpleural sparing, very suggestive, and a peribronchovascular predominance, which is uncommon for UIP. So there are other fibrotic infiltrative lung diseases, the chronic stage of hypersensitivity pneumonitis. What are the differences with UIP and IPF? The apical predominance and the fact that there is a mosaic attenuation due to small airway disease. This mosaic attenuation corresponds to air trapping if we perform an expiration CT. The fibrotic stage of sarcoidosis is characterized by an upper or mid-lung predominance, and you might have other additional CT features suggestive of sarcoidosis, especially micronodules of perilymphatic distribution. And lastly, in pneumoconiosis, you have an upper or mid-lung predominance. So this is a fibrotic stage of sarcoidosis. You can see that there is no involvement of the lower lobes. Here, very characteristic of sarcoidosis with a hilo-peripheral distribution, mid-lung involvement. And here, chronic HP, chronic hypersensitivity pneumonitis with these areas of mosaic attenuation. You can see here very low attenuation with a lobular distribution, which suggests small airway disease. And for asbestosis, the presence of pleural plaques is suggestive. Recently, there was a publication in November 2017 for new criteria for UIP, but before that, we used to use that classification from 2011, considering three possible categories. When you have a fibrotic disease with subpleural basal predominance, with predominantly reticulations and presence of honeycombing, this is sufficient to establish diagnosis of a UIP pattern. If you have all these signs, but if honeycombing is lacking, it's called possible UIP. And there are 7 criteria which are inconsistent with UIP, for instance, an upper or mid-lung predominance, or a peribronchovascular predominance, micronodules, cysts, mosaic attenuation, or an extension of ground glass predominant over reticulations. So this does not mean, when you have these CT patterns, that UIP is impossible, but for category 2 and 3, you will need to perform an open lung biopsy. So this is typical UIP because of the presence of honeycombing. Here you have the subpleural basal predominance, reticulation predominant over ground glass, but no honeycombing, so it is possible UIP. And if you have one of these 7 criteria, it is called inconsistent with UIP pattern. So according to these criteria, lung biopsy was necessary for categories 2 and 3, and not necessary when you had a typical UIP pattern. But there have been new diagnostic criteria recently published, in which the possible UIP changes for probable UIP pattern, meaning that even though you don't have any honeycombing but the other CT features, we accept that for a UIP diagnosis. And so lung biopsy is only necessary when there are indeterminate CT pattern for UIP or CT features most consistent with non-IPF diagnosis. It corresponds to the former inconsistent with UIP pattern. So we're going to review this. Now here it's a typical UIP, again basal and subpleural predominance, reticulations more important than ground glass, presence of honeycombing, and absence of features to suggest another diagnosis. Probable UIP, it's nearly the same, except the fact that you have no honeycombing. So in these 2 situations, no need to perform lung biopsy to start the anti-fibrotic treatment. Then we move with the 4th category, most inconsistent with non-IPF diagnosis, when it is upper lung predominant, such as in this case, or when it is characterized by an extensive ground glass, like in this case, or when there is a peribronchovascular predominance. This does not mean that UIP is impossible, but to prove it, we will have to perform a lung biopsy. Then presence of micronodules, presence of cysts, presence of consolidation. These are features most consistent with a non-IPF diagnosis. And lastly, mosaic attenuation, more suggestive of chronic hypersensitivity pneumonitis. Then I will have to say that this third category that they call indeterminate is not clear for me at all, because I don't see the difference between indeterminate for UIP and CT features more consistent with non-IPF diagnosis. If we look at the figure caption here from the paper, they say that this is a CT pattern indeterminate for UIP because of peribronchovascular extension, but it's a criterion for category 4, and patchy ground glass again, and mosaic attenuation. So I don't understand why they make the difference between those two. It's not very clear. And lastly, I will briefly mention another form of fibrotic lung diseases that we saw with the case, PPFE, Pleuroparenchymal fibroelastosis. As my colleague mentioned, it's characterized by a fibrosis of the visceral pleura. It has an upper lung predominance. It's most often idiopathic, but it can be seen after some context like bone marrow transplantation, and it's not linked to smoking. This is a case of my institution, thickening of the upper of the pleura and subpleura regions of the upper and mid lung, occurrence of pneumothorax, and frequently associated with other sort of fibrosis, especially UIP. The prognosis is very poor, and you can see here the complication of pneumothorax. So, to summarize some take-home points, the two CT features which make you pretty sure that the patient has a pulmonary fibrosis are either onecombing or traction bronchiectasis. Because of the frequency and the severity, you should consider IPF for every fibrotic ILD. Recently, the Fleschner Society suggested a classification into 4 categories: typical, probable, indeterminate, most consistent with non-IPF. For probable, you have all signs except that onecombing is lacking, but this does not require surgical biopsy anymore. Surgical biopsy is necessary for categories 3 and 4 because these categories do not exclude UIP. There are other features suggesting UIP-IPF, age above 65 years, asymmetric involvement, and pulmonary ossifications. So just for you to have some images in mind, UIP, NSIP, and PPFE. Thank you for your attention.